what I'm going to do initially, I'm going to explain, right, the heart cycle, and essentially, right, all the parts of the heart that have the property of automaticity. Once we do that, then we're going to talk about how that automaticity is affected with different dysrhythmias. And following that, we're going to apply the pharmacology. We're going to employ the drugs that are found in your REMAC protocols, but essentially, right, the general principles of antiarrhythmics that will apply here. So we'll go through it. So the first step you probably learn, right, the heart has all these properties. It has the property of automaticity, excitability, conductivity, contractility. But what I want to emphasize is this property of automaticity. Do you think all parts of the heart are able to do it? All myocytes? No. Right? Which parts of the heart are able to do automaticity? Right? So yeah, so Purkinje fibers, right? So what you're saying is 100% correct, right? So here they say the property of automaticity. So what this basically means, they're able to initiate an impulse without, right, without the external or nervous system stimulation. And that is very, very important, right? The other properties of the cell, like excitability, right? It's basically they're picking up the fastest impulse, conductivity, via gap junctions to move impulse from cell to cell, and contractility, the mechanical aspect of contraction. These three properties, right, all myocytes share. But this one is inherent to the particular fibers, right, which is the SA node, the AV node, and the Purkinje fibers. And now what I'm going to do is I'm going to diagram this out, and then we'll talk about, right, how this all applies. Right. So first thing I'm going to diagram out is the heart. So we're going to say this is the heart, and this is the atria. Right, we have the left and right atria, and then in between, right, we have the septum, which does not allow impulse propagation. Here we have the AV node, right, and then from here we have the ventricles. Right, the left one is a little bigger, and then I'm going to draw. Here we're going to make this part the SA node. This part here would be the AV node. And here we have right bundle of His, and then we have the right bundle, and we have the left bundle, and it has two fascicles, right? It has the anterior and posterior. And here is we have the Purkinje fibers, the Purkinje network, right? That's coming out to the ventricles. So maybe. And can anyone tell me what's the normal rate for the SA node?
60 to 100.
60 to 100, right? So normally SA node fires 60 to 100 and beats per minute. And who could tell me what's the normal AV node?
40 to 60.
40 to 60, right? For the AV node, right? 40 to 60 beats per minute. And what about the Purkinje fibers?
40 to 20
or 15, depending on the literature.
Good. So would say that again?
16 to 20 or 15, depending on your literature.
So it could be, so truly speaking, right, they will alternate, right? We're going to keep it basic. We're going to say the rate here, right, would be 20 to 40. Right, 20 to 40, roughly speaking, right? Usually, yeah, it's probably like 15 to 20, the inherent rate. But for this, we're going to say it's about 20 to 40 beats per minute, right? So this is your heart, right? And these are the cells, right? These cells have the property of what? Right? These cells have the property of automaticity. And it's very important to understand this when we start talking about, right, different conditions that cause tachyarrhythmias or bradyarrhythmias, right? So now that we know these cells cause, right, automaticity and this ability to basically propagate action potential without stimulation of the sympathetic or parasympathetic nervous system. And now what I'm going to draw is, I'm not drawing the EKG. I'm drawing, you remember I drew a neuron, the action potential for a neuron. I'm going to draw action potential for these cells, right?
Everybody knows how to get the nice one tomorrow? I'll see you guys tomorrow.
Thank you. All right, so now I'm going to draw action potential, first starting with the SA node. So I'm going to take this marker here, right? And I'm going to say, for the SA node, this first line, right, is going to be threshold potential. And this line here is the resting membrane potential. And for the SA node, it's roughly also about 60 to 70. So we're going to say maybe minus 60 millivolts, right? But
That's resting or threshold?
resting. 60 or 70 is resting, right? 60 or 70 is resting. And when the SA node fires, the shape, right, of the action potential looks something like this. Right, so this was the SA node, and roughly speaking, right, let's make it minus 60 millivolts as our resting membrane potential. Let's say threshold was minus 40, right? Now, the next thing that I'm going to do, so this was the SA node, let me move it over here, right, this was the SA node. The next one I'm going to draw is going to be a cell from the atria. So I'm going to take a cell from the atria, right, any cell here, right, and I'm going to draw it. Do the atrial cells have the property of automaticity? No, they don't have the property of the automaticity. The only cells that have property of automaticity is SA node, AV node, and the Purkinje fibers. The cells of the atria, they don't have the property of automaticity, but they have everything else: excitability, conductivity, right, and contractility. So now I'm going to draw the same thing. So let's say this is the resting membrane potential, right? This is the threshold potential, and the atria, it's maybe right resting, maybe minus 90, right? Threshold potential is here. Let's say it's minus 90 millivolts. And now I'm going to draw how it looks, right? Right, so this was the atria. And before I ask you the next question, right, I want you to pay attention to the slope here, right? So pay attention to the slope. Next thing I'm going to do is draw the AV, right? So AV is going to be here, right? Let's do resting membrane potential, threshold potential, and this is going to be the AV, so make it purple. And it's going to be like this. Right, so this is our AV. Let's say resting membrane potential might be minus 60, minus 40. This is the AV, and I'm going to move it here. Right. The next, right, I'm going to do a ventricular cell. Right, so I'm going to take a cell from the ventricles. Right. Do ventricles have the property of automaticity? No, they don't. Right. No, they don't. So I'm going to draw again. And in the ventricle, resting membrane potential may be minus 90. Minus 90 millivolts. A little bit bigger. And the shape of this is like that. Right, and the final one would be the Purkinje fibers, right? The Purkinje fibers will be here. So resting membrane potential, threshold, and Purkinje are going to be here. All right. This is our Purkinje. So now my question now is as follows, right? What do you notice about the slope of the cells that have the property of automaticity, like the SA node, the AV node, right, the Purkinje, versus the cells of the atria and the ventricles, right, that do not have the property of automaticity? What do we see?
It's a lot shallower.
What is shallow?
It's not as steep.
It's not as steep, right? So this portion here, right? You see how this is risen, the slope is risen here, but for the atria and ventricular cells, we do not have that, right? And the other important thing to note is this, right? Why do I have this up here, right? If I take all of these cells together, the SA node, the AV node, and the Purkinje, right? and I come over here, right? I come over here, I will draw, right, my resting membrane potential, and this is my threshold. The first one, I'm going to draw the slope of the SA node. So the slope of the SA node is like this. The next slope I'm going to draw is the AV node, and then I'm going to draw the Purkinje fibers. So based on the slope, right, what do you see? So when I'm saying the slope is, it's like this, and then it becomes the signal, right?
Would it be that the threshold, it takes a little bit longer for the threshold,
For which one? For which cells?
the Purkinje?
Good. So which one is going to hit threshold faster?
I see.
Excellent, right? And then the next one is AV, and the next one is Purkinje, right? So that's exactly right. So if I ask you what's the normal pacemaker of the heart, all you're going to tell me is what? SA node. And the reason why it does it is because does it do it? On the cell surface of the SA node, right? It has the leaky sodium channels, right? And those leaky sodium channels that allow movement of sodium, they're much faster, right? As opposed to the channels of the atria and the ventricles. And they allow much more rapid movement of sodium inside. And this allows it to trigger, right, the impulse. And why not? And the next question being, if this is the pacemaker, right, and it triggers, why don't the AV node and the Purkinje also fire?
Because that one fires faster.
But why don't they
Because
fire?
the ventricles need to fill up before they shoot the blood out of them.
So that is true, but that's not the reason why. Yeah,
Isn't it electrical signals start from SA, then go to AV, so SA goes first? Isn't it how it goes?
that is true. But I'm saying, why are these not firing? When this fires, why doesn't this fire and this fire?
Because depolarization is already happening at the SA for the atrium.
For the atrium. So the reason it doesn't fire is because it's going to be overdrive suppressed. So what I'm saying, once this fires, it's going to inhibit the AV and Purkinje by overdrive suppression. And why is this occurring? Is because the cells, all the cells, have the property of excitability, and they're always going to take up the fastest cell. And the fastest cells being the SA node, that's what everybody's going to uptake. Yeah.
If the SA node is the only site in the atria that is capable of automatically, how do we have wandering atrial pacemaker?
Wandering atrial pacemaker. So the cells, right? All the myocytes have this property of excitability, right? And then they will, if they have that property, they will take the pace of the fastest cell. But that's an abnormal rhythm, right? That's not a normal sinus
Where
rhythm.
does it come from?
Yeah, we'll talk about it. I'll get to it, right? We'll get to it. But for now, I want you to explain the basics. The basics is sinus rhythm is usually initiated, right, by the SA node. Why don't these fire? Is because they overdrive suppress, they're inhibited, right? However, if let's say I take out the SA node, right? Let's say I take away the blood supply and it stops working. As the time goes by, right, these are no longer inhibited by overdrive suppression. So the next fastest one that's going to fire would be the AV node. So then the AV node takes over as the pacemaker, right? Unless there's something else going on. But normally speaking, that's what usually happens. Now, so then my question is this, right? I just said, right, the SA node, the AV node, the Purkinje, they have these leaky channels. They have sodium coming in much faster, so they reach the threshold potential much faster as opposed to these cells on the atria, right, or the ventricles. So my question is, how do the atria and then the ventricles depolarize if this is absent from them?
Isn't the internal
Internodal? Well, there's no internodal. It goes cell to cell, right? But I'm saying is, if the SA node fired, right, we have the slope, but these cells don't have the slope. How do they get action potential coming to them?
No, again, it's excitability and conductivity. It travels from cell to cell, and then that hits the voltage gate. For the
So
next
there you
cell.
go, the conductivity. But so you're correct, the property of conductivity, but what exactly brings,
Refractor or something?
not the refractory, they have the property, so all cells have property of conductivity. But what's specific to these cells? Can you tell me the property of conductivity?
That as the electricity, they have the rings. They have a name.
Yes, they do. What's the name?
Intercalated rings.
Excellent, right? So perfect. They have the intercalated discs. I'll show you the picture. They have intercalated discs, and intercalated discs have desmosomes, so they keep adhesion of cells together. And the other very, very important thing is they have something known as gap junctions. Gap junction is basically like electrical windows that connect cells to cell. So the sodium, remember, that came in, right, and this sodium right here that caused the depolarization, some of this sodium is going to trickle via gap junctions to the neighboring atrial cell. So let's say this is the atrial cell, this is the SA node cell. So once the SA node right, fired, some sodium will trickle in via gap junctions, right, to the atria. And then the atria will depolarize, right? So the atria will depolarize, and then the impulse will propagate further, right? So the same thing for the ventricles. Via gap junctions, it will propagate. Let me show you. So you see how they work, right? I mean, I showed this before, but it's important enough to show you guys again. Right. So here we actually have the cardiac tissue, right? So they show you intercalated discs, these black lines here from the cardiac muscle, and they say, right, so what is the purpose of the intercalated discs? They have two functions. First, they have the desmosomes, right, which prevent separation. So basically, they adhere cells together, right? They prevent separation during contraction. And then the next very important thing, they have gap junctions, and they facilitate direct ion exchange. Ions are charged particles like sodium, potassium, right? So, and they have the contraction. And one more image, right, to show you, right? So this is the striated muscle, right? And the cardiac muscle has these intercalated discs, which are pointed over here, right, where you see. So this is how they propagate impulses from one cell to another, and this is how we have movement of the action potential, right? Any questions so far? No questions? All right. So the next thing that I want to do is, and at this point I think you guys will appreciate this probably better. Over here I'm going to draw a big myocyte, and I'm going to take a heart cell from the ventricles, right? I'm going to take a heart cell from the ventricles, and I'm going to explain to you how the impulse propagates. Before I do that, one thing that's very important to note is this, that SA node and the AV node, right, that I drew here, their depolarization is not sodium dependent. Their depolarization is calcium dependent. So what I mean by that, when a little bit of sodium comes in and it comes to the threshold, right, there's no sodium voltage gated that opens up. What happens is there's voltage gated calcium channels that open up, and a lot of calcium comes in and causes this, and the rest is by potassium. So for SA node and the AV node, depolarization is done by calcium, right? So that's what you want to write down. But for almost other cells, the depolarization is done by sodium. Is that clear? So now let me draw a heart.
Calcium?
Calcium voltage gated channels. Remember I said cells are bags of potassium in a sea of sodium and calcium. There you got it, right? So for this cell, the SA node and the AV node, this depolarization is not done by sodium, it's done by calcium. But everything else is done by sodium. I'll tell you why.
There's a calcium channel that opens up? You said that?
The voltage gated calcium channel opens up, a lot of calcium comes in, and it will cause this depolarization. I'll tell you why this is going to be important in a moment when we start talking about the pharmacology. So here I'm going to draw a heart cell. I'm going to draw a myocyte, and I'm going to take this ventricular cell, right? I was showing you an example. So if I take a ventricular cell and I draw a big ventricular cell. But this red color is a little. It's gonna be a purple cardiac cell. Purple cell. Alright, so this is a cell from the heart. We're gonna say this is a ventricular myocyte, right? And we said at rest, the resting membrane potential is usually negative, right? So the entire cell is negative. And the resting membrane potential for the myocyte, ventricular myocyte, is roughly minus 90 millivolts. That's the resting membrane potential. And at this point, right, I think everybody knows, right, the cells are bags of potassium and a sea of sodium. But for the heart, I'm also going to say there's what else? Calcium, excellent, right? So calcium is found outside. Calcium is found outside, and inside there's a lot of potassium. I'm going to make it green. Right? So this, as long as you remember, I think this will help you answer a lot of questions. Right? So cells are bags of potassium in a sea of sodium and calcium. Right? So that's what we have. So we said resting membrane potential was minus 90 millivolts, and on the surface of this myocyte, we have some leaky sodium channels, right, that facilitate movement of sodium in and out. And if there's enough stimulation, that enough sodium trickles in, right, it's able to take the negative 90 resting membrane potential to minus 70 millivolts, right, which is the threshold, right? So it's able to do so, and let me draw. Right? So now it went to this point, and at this point, what happens is, right, voltage gated sodium channels open. You guys remember in the resting phase, the sodium channels, so let me draw. This was a sodium channel in the, right, resting phase, right? The moment I hit threshold, what happens to this channel? Right? The activation gate opens, right? And it becomes active. So this opens, this is open. So this was activation gate, this was an activation gate, right? Activation gate opens, this is an activation gate. So once the activation gate opens, this sodium channel is going to be in this configuration. We say it's active, and a lot of sodium is going to rush in. And this rush of sodium, performed by voltage-gated, right? Voltage-gated sodium channels is what moves this membrane from minus 70 millivolts up towards a positive number. It wants to reach its equilibrium potential, right, at about plus 63, right, or around there. But before it comes to that point, right, something else happens, right? Let's say it comes to plus 10 here, right? Let's say plus 10 millivolts. But before it can reach its equilibrium, right, potassium channels open up. And now what's going to happen, a lot of the potassium is going to efflux out. So potassium is leaving. So it starts to take this membrane, right, back towards negative. But there's something different between the heart and the neurons. The heart has, right, in addition to sodium and potassium, right, it has these channels. They're called calcium channels, right? And they're also voltage gated. And at this point, right, as the potassium is leaving, calcium channels open up and a lot of calcium is coming in. And this movement of calcium is going to not let this drop too fast. This will not let this phase drop too fast. So we have this like plateau, right? It's plateauing. Why is it plateauing? You have plus charges leaving and you have plus charges coming in, and they kind of cancel each other out. So plus is leaving, plus is coming in, right? So this is what's occurring. At this point here, right, what happens is as follows, right? We said the sodium channels were in active state, and they're going to become into inactive state, so they switch from this configuration to inactive state, and this is open, right, but this is shut, so no sodium can entrain here. So this inactivation gate shuts. Now our sodium channels look like this, right? So sodium does not come in, right? So no more sodium coming in. And then potassium is leaving at much faster rate than the calcium is coming in. So as time goes by, the efflux of potassium exceeds calcium. So calcium gate closes. No more calcium is rushing in. But potassium is allowed to go out until it reaches its equilibrium potential, right, which is like minus 80, right, millivolts. And it goes something like this, right? So now we get to the stage. Now, this portion of this action potential has phases, right? So this phase is called the phase 0, and phase 0 was what? All the sodium coming in. So phase 0 is what? Depolarization, right? And then at this point, right, we had potassium leaving and calcium coming in. So this was phase 1 and phase 2, right? So let me take the red color. It was phase 1 and phase 2. And here we had the potassium leaving, so this was what? Phase 3, right? This was final phase 3. And this portion where it finally, right, repolarizes, this is phase 4. Right, so here would be phase 4. Right? So one more time. Sodium coming in would be phase 0. Exchange of calcium and potassium, phase 1 and 2. Potassium leaving is phase 3. And then when it gets to the resting potential, this is phase 4. And here, right, for the next impulse to come in, remember, these have to flip back to what? The resting configuration. So for us to continue this, right, this has to go back to the initial resting state. So here, the sodium channels have to be like this. They have to be in resting phase in order to facilitate, right? So if I draw an EKG to superimpose on this rhythm, the EKG would look like this. Let me take it. So this would be the P wave. This would be the QRS. And this would be the T wave. Right? So if I drew the EKG, this would be the P wave, right? P. This would be the Q, this would be R, S, and T. So if you notice, right, from here to about here, right, from here to here, on the blue, what do we call this phase? What kind of refractory?
Absolutely.
Absolute. And why is this absolute? Who could tell me why this is absolute?
No matter what you do to it, it can't be polarized.
But why?
It's polarized. It's already depolarized. You can't depolarize it again.
So let me repeat my question. So all of you saying, what you're saying is correct. From this point to this point, we call it absolute refractory period. No impulse that comes in can trigger an impulse. And my question is why?
Is it because it's at a negative 10?
Not because it's not negative 10. Sorry.
The whole function is already in place for all the sodium channels, calcium channels.
But why can I trigger the next impulse? There has to be a reason. Because from here to here, what do we call from here to here? Relative refractory, right? So from here to here, right? And what's the difference between them? Absolute and relative.
We're stimulated by strong
Yeah.
something, whatever.
What Frank was saying is 100%. A strong enough stimulus can trigger, right? Can trigger an impulse. And my question is why?
Because it's already at the voltages for the gates to be in their open state. You can't reopen it more and force more into it to change the polarity.
You're on the right track, but your concept needs a little bit of clarification, right? So what you're saying is correct. So in absolute refractory period, all the sodium voltage gated channels, they are trapped in this inactivated state because the inactivation gate was shut. So over here, all of them are in this. But as the time goes by, they slowly start to revert back to the resting state as the potassium is leaving for repolarization to occur. So here to here, maybe 60% of the channels have already switched to this configuration. And strong enough stimulus can come and then it's going to cause the next impulse to propagate. Everybody follow? So the reason why it doesn't happen in absolute is because all of them are in active phase. The reason why it may happen in relative phase is because you see on the T wave, this is where repolarization is occurring. So some channels may have flipped already into the resting configuration, right? And that can cause the next impulse to come in and trigger, right, an abnormal, right, action potential to propagate. So this is why it's important to know. Now, so we learn, right, phase 1, phase 0, phase 1, phase 2, phase 3, and phase 4, right? What is occurring for this cell. I was explaining to you guys, right, for SA node and the AB node, this depolarization is not done by sodium, it's done by calcium. And for all other cells, it's done by sodium, right? So all of this is clear? Any questions here? So now, why was I explaining all this? You know, what was the purpose of all this? So now what I'm going to show you, I want to show you a chart. Right? Now I'm going to show you a chart of the drugs, right? So if all of you are going to be working in the field, you're going to be definitely using these drugs. So this is called Vaughan-Williams classification of antiarrhythmic medications. So this is pretty much, they classify all the antidysrhythmic drugs into these categories. So the first category, right, would be sodium channel blockers, right? In your protocols, out of these drugs, which ones do you have?
Lidocaine.
You have lidocaine. You have class 1B, right? Lidocaine. That beta blockers. In your protocols, right? You have this, but not for tachyarrhythmias. You have it for something else, for blood pressure regulation. So beta blockers make class 2. Then we have potassium-channel blockers, which is class 3. Out of these drugs, which ones do you have? You have amiodarone, right? One thing you want to remember about these drugs, all of these drugs, they prolong the QT interval, the potassium channels, all of them. So they make the QT interval longer. And then the last one, we got the calcium channel blockers. Out of this class, which ones we got? Diltiazem. And then some books will have class 5, and class 5 would be drugs like adenosine and drugs like atropine, right? Included there, digoxin, right? Class 5. But for now, if you remember these classes, right? You should have an idea, right? How, what you're going to do. So now I'm going to explain to you, right, how these drugs actually work. So let's say we got a guy, right? You put him on the monitor and he's having a very high heart rate. Let's say his heart rate is 180, right? I'm gonna draw it over here if you're able to move it to this side, right? So we're gonna say we have a guy. This is his resting membrane potential, his threshold potential, right? Draw it like this. So we got a guy, and he has a heart rate of 180, and he's firing like this. Probably make them all, they're all uniform size. So we're going to say this is how it's firing. So, and let's say for this case, he's still stable, blood pressure is good, he has good ventilation, right? He's doing well. So now we have all these categories of drug, right? So we're going to say this is the assay drug configuration, right? And let's say it's irritable, it's firing at 180, put him on the monitor, right? And we're going to say he's not having sinus tachycardia. We're going to say it's a bit older guy, right? He's not having sinus tachycardia. We perceive that it's very, very fast rhythm that may make him unstable. So out of the drugs that you have saw on that screen, right? What do you think one strategy would be, right? To reduce his heart rate just based on this graph alone. What can we do to this graph to reduce his heart rate?
Make it happen less often.
Make it happen less often, right? Good. What else? But how can we do it based on this graph? What can we do? What can we adjust on this graph to make it happen less often?
Calcium of sodium that is going in.
Right. So we can adjust, right? So the strategy overall, right? So the overall strategy would be this. So let me show you the overall strategy. So we said, right, this was our threshold potential, right? And this was our resting membrane potential. So one strategy we can do is, one strategy could be we could raise the threshold potential that is here. Another strategy we can do, we can lower the resting membrane potential, right, number 2. So this could be here. Another strategy we can do is we can reduce the slope. So instead of slope going like this, the slope can go like that. Right, so this 1, 2, 3, reduce slope. Right, and then, right, in addition to what else can we do? We can have a combination of these things. So for example, if I give this person the following drugs, if I give him either a calcium channel blocker, right, or I give him a sodium channel blocker, what both of these drugs do is the following: they lower the slope and they increase the threshold potential. So if I give this guy a sodium channel blocker or a calcium channel blocker, this is how his So if I give him calcium or sodium, I lowered his slope I raised his threshold potential, and now it fired, right? Now, if this was coming from the atria, right, and there was a supraventricular rhythm, do I want to give him a sodium channel blocker, or do I want to give him a calcium channel blocker, and why?
You want to give them a calcium channel blocker because it will affect the atrial rate, but it won't affect the ventricular rate.
Good, right? So, but the other thing, right? Remember we said the SA node and the AV node were depolarized by what? Calcium, right? So by giving them sodium channel blockers, do you think they're going to be as effective? No. So that's why if you look in your protocols, right? Diltiazem is usually given for which rhythms? Diltiazem, yeah.
Isn't it, doesn't it, drop the BP?
It does drop the BP.
So what are we doing for?
But for which rhythm? Supraventricular, meaning above the ventricles? The rhythms that originate here? Or the rhythms that originate from here?
Isn't it the lower one?
The ventricular is the supraventricular. And why we're giving for rhythms that are supraventricular is because the supraventricular rhythm, right, I say AV node, they'll be more calcium dependent. So a calcium channel blocker is given for supraventricular rhythms. They'll be more calcium dependent. Why do you think it lowers the blood pressure? Let me have somebody else. Huh? Not the preload. Why does, yeah.
Does it increase the threshold point?
No. Why does the calcium channel blocker also lowers the blood pressure? Remember the smooth muscles, right? The smooth muscles of the arteries. They contract how? By calcium. Calcium comes in and causes contraction. You guys remember from the muscle? Right? Calcium causes the contraction. So if I give you a drug that blocks calcium channels, not just on the heart, it's going to block it other parts of your body, and then block the calcium channels on your arteries. Right? Calcium comes in, can it cause the contraction? No, so you're going to have vasodilation. Vasodilation is going to drop the blood pressure. That's why some doctors may tell you, before you give Diltiazem, you want to give them calcium chloride as pre-treatment, so that when you give this drug, your blood pressure is not going to drop.
Is that cardizem?
Cardizem is Diltiazem, yes.
Brand name. Okay.
Correct,
Yeah, okay.
correct. Right? So those cardizem, Diltiazem is for the supraventricular rhythms. Why? Because they're more responsive to calcium. Right? Now, what if this rhythm was ventricular in nature? Let's say at wide complex tachycardia. Do I want to give them Diltiazem or let's say Lidocaine, a sodium channel blocker? Why Lidocaine? Because they're sodium, right, dependent. So what you want to write down for your notes, what you want to remember is this: both sodium channels. Let me write it here. Both sodium channel blocker, so sodium blocker, or calcium blocker. What it does is it will lower the slope, right? It will lower the slope, and it's going to raise the threshold potential. So your impulse propagation is slower. So you see how we slow down the heart rate? So if this guy was SVT, I would want to give him a calcium channel blocker. If this guy was from the ventricles, right, he had VTAC, I may want to consider a sodium channel blocker like Lidocaine, right? Now, out of these strategies, right, what else can we do? So imagine the guy with the SVT, right, heart rate of 180. The next thing you probably learned in your protocols, right, we have something known initially as vagal maneuvers, right, vagal maneuvers, and the other drug you could have tried was adenosine, right? What do you think both of those drugs do? Vagal maneuver or adenosine? What do they do based on this graph that we have here?
I think they extend the slope.
They do what?
Extend the slope.
Extend the slope? So they will not extend the slope. What they will do is, huh?
It would decrease it?
It will decrease the resting membrane potential. So both drugs, well, the vagal maneuver is not a drug. So vagal maneuver plus, right, adenosine is going to do this, number 2. It's going to lower the resting membrane potential. So if I lower the resting membrane potential, right, I'm going to draw it in pink, it's going to look like this from here to here now. Right? So the threshold was still the same, but I lowered my resting, so it takes longer to reach threshold for the impulses to fire, right? Who could give me an example of a vagal maneuver? Like you got a guy, he's stable, heart rate 180, right? Blow to syringe, all right, so I get, it's good. Why wouldn't you ask him to bear it down? how would you ask somebody? Like, let's say you're on the street, how would you ask somebody to bear it down?
I'd have to take a shit.
And what if they do? What if they actually do?
Then they take a shit. That's
Well,
their
you know,
problem.
that's a problem, right? And how do you
They're
think,
still bearing down.
yeah, so the syringe method is actually good. It was from the revert trial. How effective do you think it is?
I don't know.
You tell me.
I had a guy that they tried to do that and he didn't understand it, so it didn't work.
Good. So that's so that's a little different, right? He didn't understand the concept, right? But they did a trial. I'll show you what they did. So there's a video, right? They gave a syringe to the guy. They told him to do that for about I think 10 seconds, right?
Then you pass out.
I'll show you. And then what they do is they lower him down and they raise his feet. This was from the revert trial. So yeah.
Does that do anything with intrathoracic pressure?
So intrathoracic pressure. So I'll tell you. Well, let me turn this on first, right? I will ask you how it works. So my next question will be how it works, but it's not with intrathoracic pressure. But I like that you're like thinking how it's going to work. So this is the guy, right? Yeah, right. So they give him a syringe. He's counting, I think, up to 10, right? And they tell him, right, blow out through the syringe, right? And she's counting for him. And then what they're going to do is they're going to lay him flat and they're going to raise his legs. And then you're going to see the monitor. They use the MRX Philips, the ones we have actually, that were discontinued. Look what you see here. SVT. What happens? See how it broke? Right. So his heart rate was like very fast, and you see how it's coming down. So this is called vagal maneuvers. This is the revert trial. Let me just go back to the EKG so that you guys, if you missed this one, right? So they raise his legs. What's the heart rate? Let me see. 209. 209. So now you see it came down, right? The heart rate came down, so the vagal maneuvers work, right?
No P waves.
So what vagal maneuvers do? So what vagal maneuvers do, right? We just said, right? Both vagal maneuvers and SVT will lower the resting membrane potential down, so that it takes longer to reach threshold. So my question, right? He was thinking at the threshold. My question is, how does this work? How do vagal maneuvers work?
They hit a nerve that activates the parasympathetic.
Yeah.
something.
How? Explain to me how.
I don't know.
Remember we talked about that with neuro when I drew the diagram. So it has to do with a diagram to give you a hint.
So you hit the nerve, like you touch it or something, or it activates. I don't know.
So before the syringe, right? I don't know if you read in your book. We used to do carotid sinus massage. We used to massage the carotid artery right here. So a patient with this rhythm, he would get a massage on the carotid artery. The reason why we stopped doing that is there was a possibility of shearing off plaque, right? They'll plaque shearing and then they may get a CVA, right? Stroke. So we stopped doing that. But think about this, right? Follow through. Let's say this is a hose, and I massage it. Am I pressing on it? I'm pressing on it. Do I make it the lumen smaller when I press on it? If there was water in this hose and I press on it, pressure going up or down? Pressure is going up. So remember, the baroreceptors were found where? The carotid, right? The carotid sinus and the aortic arch. So on the carotid sinus, I'm massaging. Is the pressure going up? So the body's thinking my blood pressure is going up. So they're going to send through vagus and glossopharyngeal nerve, the afferent nerves. They're going to say, hey, my BP is going up to the tractus solitarius, so the nerve, right, of the solitary tract. And they're going to say, all right, I need you to activate the cardiac inhibitory center to release what? Acetylcholine on the heart, right? If acetylcholine comes on the heart, what is it going to do to the heart? Reduce the heart, right? So that's why we did that. That's exactly how it happens. It stimulates, right, via the glossopharyngeal and the vagus nerve. It stimulates that your BP is going up, and the response is to slow down the heart rate with acetylcholine on M2 receptors on the heart. So that's how vagal maneuvers work, and how, right? The other thing we're doing them, right, is adenosine. The adenosine is giving rapidly, right, IV, right, to slow down conduction through the AV node, and it does so by lowering the resting membrane potential. Just a good thing if you want to write down on your notes, right? Stable patients get medicine. Stable patients get medicine. Unstable patients get Edison. So electricity. So stable medicine, unstable Edison. How do I know somebody's stable or unstable? There you go.
Mental
Well,
status.
good. Mental status and vitals. So if they AMS and my blood pressure is less than 90 systolic, right? They are probably unstable. If my patient is maintaining well, blood pressure is above 90, they're probably stable. So stable patients, we're going to give them medications first. The medications we're talking about here. So now we covered, right? We talked about adenosine. We talked about vagal maneuvers, right? We talked about sodium channel blockers. We talked about calcium channel blockers, right? There's the way beta blockers work, right? Even though you don't give those drugs for tachyarrhythmias for the protocols, the way beta blockers work is they reduce the slope. So the only thing they do is they reduce the slope. So the beta blockers will be like this, right? They will fire. So the slope will be reduced for the beta blockers. So the beta blocker property is to, instead of having slope like this, what a beta blocker will do is it will make a slope like that, right? So it will reduce the slope. Right? Beta blockers reduce the slope. What else? The other very, very important drug you're going to give quite often is potassium channel blocker, right? A potassium channel blocker in your protocols primarily is what? Amiodarone, right? How do you suppose amiodarone works?
Slows down the release of potassium
Good.
relative refractory.
So look, so good. So I give you amiodarone. So let's say this amiodarone, and amiodarone comes here and it binds to this channel. Can potassium leave?
No,
No. So what do you think happens to this relative refractory period?
it happens faster.
Not
stays
faster.
there.
It's going to become slower because potassium. So I'm blocking these channels, so potassium is leaving much slower. I have a lot of these potassium channels, but some of them are being blocked. So potassium is leaving slower. So what's going to happen is this.
Repolarize slower.
So instead of being here, it's now like this.
It takes longer for the cell to repolarize.
Yeah, and it also, by doing this, it also keeps the sodium channels in inactive phase. By making this phase longer, it keeps the sodium channels in this inactive phase, so the next impulse cannot trigger. So if I give you, right, amiodarone, which is a potassium channel blocker, I'm going to prolong, right, phase 3, right, phase 3 of your action potential, and I'm also going to keep the sodium voltage gated channels in inactive phase longer. And what it will do to the heart rate is going to slow down the heart rate. Ideally, we usually give these drugs for ventricular rhythms, right? Ideally, we give the drugs for the ventricular rhythms, like ventricular tachycardia, right? VTach with a pulse, right? So that's what it does. But it also prolongs the QT interval. So this can actually send these patients to an abnormal dysrhythmia, right? It can send them, predispose them to torsades, right? Because it prolongs the QT interval. So now, right, we talked about, right, sodium channel blockers, calcium channel blockers, vagal maneuvers, adenosine. We talked about amiodarone, right, how it blocks the potassium channels and what it does to this phase, right, relative refractory period. Any questions so far? All these drugs, all these antiarrhythmic drugs, their function is to do what to the heart? Slow it down. So what do you suppose is going to do to their blood pressure? Drop the blood pressure. All these drugs drop the blood pressure. All of them, right? All of them. So what you want to be cognizant about is these drugs drop the blood pressure. The reason why I want to say this to you is you may get this patient who has VTach with a pulse, right? And you start to infuse amiodarone, and amiodarone prolongs the, right, this phase 3, right? Less potassium is leaving, so this is longer. And all of a sudden, right, the blood pressure starts to drop. The BP is dropping, and if you don't have their monitor connected and you're checking the BP, what you're going to find is this: all of a sudden, your nurse patient has no pulse, and you're going to say, okay, this patient is now in pulseless VTach. We got to defibrillate and do everything like that. Is that so? How come? You got a patient, right? Let's say he's ventricular tachycardia, VTach.
Okay.
He has a pulse, he has good mentation, and I said all these drugs drop the blood pressure. So you start to infuse amiodarone, 150 milligrams in a 100 ml bag. You're infusing, all of a sudden you notice he's becoming altered. You check his pulse, there's no pulse. What should you do immediately? Shock? Say that again?
Stop the flow of the drugs and check for a flow.
There you go, right? Stop amiodarone infusion stop the infusion because the drugs drop the blood pressure, right? The worst thing you can do is have the thing running, and then you're like, okay, he got no pulse, let's just give him more amiodarone and shock him, right? So the first thing you want to do is stop the flow of amiodarone, and then it's a piggyback. So then the next action you should do what? Open your normal saline. Open your saline, right? And then run the blood pressure, right? Check the mentation and so forth. So you run some fluids, maybe the blood pressure is going to come up. He doesn't have VTAC without a pulse. What he has is he has a paramedic who's infusing antiarrhythmic too rapidly and not checking the blood pressure, right? So I wanna say that. How did I find out? I was working CT-ICU, and we have an A line right on the patient, and this patient was super responsive. We start amio drip. He was in VTAC, and I see his BP. He was like systolic of 90. Like a few seconds in, BP drops to 60. Do you think at 60 blood pressure you got pulse? You're probably not going to be able to feel it, right? But we didn't go shocking him. What we did was we stopped the amio infusion right away, start fluids, right, and the BP came back. Put a Trendelenburg position too, right? So always be cognizant. All these drugs drop the blood pressure. That's why for Diltiazem you were saying, right, Beatrice? For Diltiazem, what does it say in the protocol? Before you could.
Slow push.
But what about the blood pressure? What does it say about the blood pressure? So you gotta, it drops the blood, so your blood pressure has to be good or elevated before you could give this drug, right? Very important. So you want to monitor the blood pressure, and it's a slow push. Why is it a slow push? There you go. Right. So all antiarrhythmic, all antiarrhythmic, all antiarrhythmic medications you give slow. You always monitor. You put the monitor in the lowest setting, like every 2 minutes on the BP, whatever you can, and you always monitor. If the blood pressure drops and your patient becomes AMS, right? First thing you do is stop the drug, stop the infusion of the drug. First thing, open the fluids, reassess, right? And then you could take it from there, right? So we talked about this. Oh, there was a question. I'll answer it right now, right? Because it's important about the ischemia. So these cells, right? How sodium came in, potassium was leaving. How do you suppose these cells get it back to the normal resting membrane potential? What did they have on the surface?
Sodium, potassium pump.
Good. They have the sodium, potassium, right? ATPs. And now I want somebody to tell me precisely what goes out, what goes in. Raise your hands, tell me. Yehuda, Erica.
2 potassium
Yeah, 2 potassium in,
and 3 potassium.
3 sodium, right? 3 sodium from that. Right. So what you're saying is correct. 2 potassium goes in, and then 3 sodium are being kicked out. Makes sense, right? And how much ATP these guys use?
25%.
25%. Now check this out. This guy, right, is having a heart attack. He's having low flow of blood to this ventricle, right? The ventricle is not being perfused, right? So this area is becoming ischemic, right? Do you think there is a lot of ATP being produced in that area? No. So good. So less ATP is being produced. If I have no ATP to drive these channels, do you think they're going to be pumping out quickly or slowly? Slowly. So if I'm pumping out slowly, what do you think is accumulating inside? Sodium, right? Because nothing is kicking it out. Good. So sodium is accumulating inside, and the cell knows I have to repolarize, right, and depolarize again in order for me to contract. So what it does is it finds an alternate channel. This is an alternate channel, and this channel does the following: able to move the sodium out, but only if it brings calcium inside. So we have now, this is not working well because we are in ischemia. We don't make enough ATP to drive this guy. So that the sodium that was accumulated here, it's using a different channel. It's called sodium-calcium exchanger. So sodium is going out, calcium is coming in. And this calcium, by the way, is positive, right? More positive coming in. Do you think your resting membrane potential will still be at minus 90? No. It's going to be higher. So it might be what? Minus 80, right? So now it's very close to the threshold potential. So now very little sodium has to come in to do what? To trigger? There you go. So that's why those patients start to develop PVCs first. Ischemia, right? Develops PVCs, right? And as ischemia progresses, PVCs become frequent. You heard about, right? Bigeminy, right? And then you may have a run of VTAC, right? Because it's becoming more ischemic. And then boom, right? The guy goes into VTAC or VFib. So how does ischemia cause, right, abnormal heart rate abnormal rhythm is because this is what happens. In ischemia, these channels not working. They are not pumping out sodium out, right, as well, so sodium accumulates. But the cell knows I have to contract, so it finds an alternate route. It's called sodium-calcium exchanger. Sodium goes out, calcium comes in, and it raises the resting membrane potential. Instead of minus 90, it's now minus 80. And it's now very, very close to the threshold. Very little sodium comes in, causes the next impulse. And
I have a
this,
question.
yeah,
So will that whole thing happen faster
yeah.
during the
So what happens now? So what happens
or
is this.
slower?
So this is what happens, right? As this comes in, what may happen with these PVCs, this was after depolarization, right? This phase.
Correct.
What may happen is this: you may have on this relative refractory if PVC hits, right? You will have this, and then this will cause possibility of polymorphic VTEC or VFib. That's what we worry about. They'll have more PVCs initially, more PVCs, the actopy, and then the problem is this: if it's frequent enough, it may come at the point of the cycle when it's relative refractory. A little more sodium came in, it was close, it triggered, right? And this we call a delayed. This is called early after depolarization. So this after depolarization and this early. It shouldn't be occurring here. It should be right. It should be here.
So that whole process is happening fast.
Correct. This is basically like happening much faster, and the problem is if it hits on the relative refractory,
You got our
there you go, you got it, perfect, right? And then there's going to be VTAC or VFib. That's why patients with chest pain, right, who are having an MI, we're always worried about them having a lethal dysrhythmia. And while we on this topic, since it's a good question, I'm going to explain to you. You guys probably heard about your regular heart attack, right? Regular heart attack is you have a plaque formation, it ruptures, right? All the platelets come in, right? Anybody heard about type 2 MI? Type 3 MI? Type 4 MI? Type 5 MI? I'll give you an example.
You're not talking about heart block. You're talking about
Yeah.
myocardial.
No, if I yeah.
infarction.
Yeah, myocardial infarction. So check this out. The guys you learned about is this. You have unstable plaque, right? It ruptures, platelets come to plug it up, right? And then patients having ischemia, and you look on the EKG, right? You see STEMI. I give you a different guy, right? They take him to the cath lab. There's no blockages, but he looks on the EKG. There's a STEMI.
Isn't that the end stemming?
That's not the end STEMI. End STEMI
The
is
other way around.
end STEMI is when you have no elevations, but this guy has elevations.
So you have elevations but
No blockage. Yeah, they take him to the cath lab. There's no blockage.
Are
He has
the
pericarditis.
arteries too narrow to adequately supply the heart with oxygen?
So give me an example of what can cause that.
Well, it's angina is
CAD?
stable or unstable if he's working his heart more than the oxygen supply.
Give me a condition.
Prince metal?
Not Prince metal.
Atherosclerosis.
No, that would be type 1. So I'll give you an example. Imagine you got somebody in nursing home. They got sepsis, right? They got fever, heart rate, and they have other comorbidities. They have diabetes. They have maybe hypertension right there, and heart rate is now beating at a rate of 120, 130, right? Because they have fever, right? And this is going on for hours, and the heart is tired. And what's going to happen if you have lack of flow to the coronary arteries? You have lack of flow because your heart is super fast, right? It's beating for days. It's going to infarct, right? But if you take them to the cath lab,
You're not going to see it.
yeah. So what do you think is the treatment for those people?
Nitrates and beta blockers, so they go
Oxygen.
Stent? There's no blockage. So you got to treat the underlying condition. You got to treat sepsis.
I was going to say
What
lower
about
the heart rate.
what about you take another guy? You take somebody who took maybe a lot of cocaine,
Oh,
and the heart rate is being 140.
hypertension.
140, right? It's the same tachycardia, right? It's going to cause what? Ischemia to the heart, and they have an infarction.
Yeah.
You take them to the cath lab, they're going to have a blockage?
No.
No. So severe bradycardia, severe tachycardia, and any shock condition can predispose the patient to what? STEMI. So I'll show you something. You were not told this, but I think it's important for you to know.
We learned a lot.
Right, so this is called a fourth universal definition of MI, if you want to look this up. But what you guys were probably taught is this, right? You were taught that there is the regular one. Let me show it. This is what you guys, this is type 1 MI, right? You have plaque, it ruptures, platelets come in, right? you have thrombus formation. This is what you know, right? This is the regular one. Now we'll talk about type 2 MI. So criteria for type 2 MI, right, is they have new ischemic changes, right, on the EKG. And what usually causes type 2, here you go, right? So here, for example, you may have oxygen supply demand imbalance. This can be secondary to shock state like sepsis, right? You can have non-atherosclerotic coronary dissection, so there's dissection of the coronary lumen itself. You have vasospasm, right? Microvascular dysfunction. You gave an example of like your Prince metals, right? And then this is your stable plaque, right? But it's very narrow. And here they show you, right, the condition. So look, here we have type 2 MI, and the mechanism is this, right? So it could be severe hypotension shock, right? And the ones I gave you, right, were sustained tachyarrhythmias, severe bradyarrhythmias. So if you look, right, for these patients, right, they may also sustain, right, an MI. They'll have STEMI on the EKG. They have positive troponins, but the cause is not blockages in the coronaries. And then the type 3, you should at least know up to type 3, right? The type 3 is essentially a patient who has sudden cardiac death, right? So where was the type 3? Type 3 right here. So patients who suffer sudden cardiac death, right? And suggestive of myocardial ischemia accompanied by new ischemic changes, right? But died before blood samples and biomarkers, and they don't find any blockages. How do you think these patients died? They probably had ischemia, right? Remember the diagram I just drew? And it landed on R1T, and they went into VFib or VTAC. They lost pulse, right? And they died. And when they did the autopsy on them, they found no blockage. Where's the blockage? No blockage. Because they were severe tachyarrhythmia. Make sense? Yeah. Right? And then the other type 5, since you're here, type 4 and 5 is basically happens in the hospital. So you have a patient who was brought in, they put a stent, and then less than 48 hours after the stent, after the PCI, percutaneous coronary intervention, right? He starts to develop new chest pain and so forth, right? New ischemic changes. And then type 5 is post-CABG, coronary artery bypass grafting. He develops pain. So,
like the
yeah, so type 4 and 5 is not going to be really pertinent to you unless you do interfacility transfers. But type 1, 2, and 3 you should definitely know, right? So severe sepsis. I actually had a call like this. I went to one of the hospitals, and the doctors there said, okay, you got this guy. He's in the ED. He's got to go to the cath facility. I come over there. They're running heparin. The patient was from the nursing home. High fever, right? Very hot, cloudy urine with a Foley bag. I look at his labs, he has positive troponin, so heart is infarcted. They show me EKGs, right? But then I look, white cells, elevated. I put him, he was on the vent, I put him on my Antiarrhythmic, Antiarrhythmic is like 28, right? High neutrophils, high white blood cells, fever, right? Cloudy urine, so yeah, he's septic, so, but they were treating them for what? For the STEMI. But if I take this guy to the cath lab, they're going to come with the cath lab. Do you think they're going to find any blockage? No. They won't. So that's why when they came there, I told the doctor, like, these are the labs, this is what's going on, and we transferred the patient to the medical ICU, right? So you have to be cognizant on that, right? And then you have to, understand that the STEMI is not only caused by the coronary thrombosis, right? You have other conditions that are causing that, right? Hopefully that's clear. If you wanna read about,
are you gonna post this?
I'll post the slides and
I'm talking about this paper.
This paper. Oh, if
The
you want.
paper's already posted on the group. Azaria sent it.
Yeah, if you want to, you could take a picture. Right, it's in the HA, and it's called Fourth Universal Definition of MI. Right, so you could read it. And then while I'll give you a break in the moment. Right. One thing I wanna show you. So show you one last thing, and then I'll give you guys a break. Let me find it. So you guys remember when we did the muscle chapter, right? We talked about tropomyosin, right? Tropomyosin, and then you had actin, right? And docking to what? Myosin, right? Tropomyosin was moving out of the way, right? And then we had actin and myosin direction. But this is what happens in the heart. We have this troponin complex. Remember, troponin is where calcium was binding to. You see this troponin I, C, and T? This troponin is found in heart. It's cardiac specific troponin, right? So if you have no problems, if you have no injury, I check your blood. Should you have any troponin in your blood?
No.
Right, because there's no injury. But when you have an injury to your heart, this troponin leaks into the blood. So then when I check your blood samples, I have elevated troponin. And there's other enzymes called CKMB, cardiac kinase, right? Myocardial band. So why are they elevated is because we know there's heart injury, but we don't know we don't know if it's an MI, if it's pericarditis, if it's traumatic blunt injury, we don't know. We just know the heart is injured. Everybody follow? So when this is in the blood, we know there's heart is injured. So now what I'm going to show you, this guy comes in, he was having chest pain, and they run his blood work. And they check for this cardiac troponin, right, which I just showed you, and they do the CKMB, cardiac kinase myocardial band. And you see, right, it's elevated. And if you look at the studies, right, that they look at these markers, they say this one is way more specific and sensitive for heart attack. This is less sensitive. So why do you have the second one?
For
Right?
any other reason?
For what reason?
Like, the other things can be wrong with the heart other than that line.
So that is correct. But what I'm saying is, when the heart gets injured, right, no matter what the cause is, both of these elevate. But why the hospital checks both of these things? Why not just stick with cardiac troponin? It's like gold
Just
standard.
to find out how long it's been.
For how
Because
long?
the CKMB takes a lot longer to come out in the blood work.
No, but this is like I come into the hospital. This is day 0. I have chest pain. Both of them elevate at the same time.
I don't know.
Anybody else?
So the severity?
Severity? But what I'm saying is, you having heart injured, right? It may be an MI, it may be some other injury, but both of them are elevating at day 0. My question is, why have both of these when we know this is way more specific? I just showed you on the other diagram. It's definitely from the heart.
What is the CKMB?
CKMB is called cardiac kinase myocardial band. It's another enzyme that's also found in the heart. And when there's injury, it's going to be basically seeping into the blood. It shouldn't be in the blood.
It's only when the heart is injured.
Yeah, when the heart is injured, these come out.
That one lasts longer than normal.
The levels are lower quicker,
The levels are lower.
like disappear faster.
All right, and good. You're on the right track. And tell me, how does that help you?
You can tell how long ago it happened. Like, if you see that, like at one day they're both gonna be there, but at 2 or 3, one of them is gonna disappear, but the score is still gonna be high. So
How does that? You're almost there. But how does this help me?
you could estimate the time frame.
No, you're almost there, but not quite there.
Is it the severity of the injury?
No,
It's not severity and
it's
it's
not severity.
You can tell.
He was very close.
It's not time.
You can tell if it's a resolving or not.
Is it what? Resolving? No.
Yeah.
No, because this is still elevated. You wouldn't know. So here's the thing. Remember I showed you type 4 MI? It's post-stent or post-CABG, right? Let's say you go to the hospital and you're having STEMI. They put a stent. You're now day 3 in the hospital in the CCU. You say, hey, doc, I'm having chest pain.
It
They
shouldn't-
they
you
run-
shouldn't have it.
They run, no, but he's having chest pain. They run his lab work again. His troponin is through the roof, and it's going to stay there until how many days?
8.
Yeah, it's going to, by day 4, it starts to clear, right? But on day 3, his CKMB should be already dropping or non-existent. Let's say I run his CKMB and compare to the first day. I see here it was elevated, and now on day 3 it's
So
elevated
what's
again.
this for new injury?
There you go. So this is a marker for re-injury. The CKMB is a marker for re-injury. So this is how they know in the hospital if they may have either problem with the stent or they may having another vessel that's thrombosed. So they know they could take them to the cath lab again and take a look. So what you want to remember, right, when you're in the hospital, when you're doing your rotations, right, always take a look. If somebody's coming in with the chest pain, always ask them, what's the level of cardiac troponin and CKMB, right? And then, right, this is the marker of reinfarction. So on day 3, this should be very low or non-existent, right? But now it spikes, it's like this. So now you know he's either having reinfarction or something is wrong with the stent, right? Any of you who do interfacility transfers, right, you may be involved, right, looking at that. So it's very good to know, right? So any questions about this? So ideally, this is not in the blood unless there's injury. I'm not saying if you have this, you're having a STEMI or you're having a heart attack. I'm saying if you have this, you have what? Injury to the heart. and then it's your job to determine, right, what is the cause of that. Make sense? Right? Type 1 MI is your standard plaque. Type 2 MI is what? Oxygen supply demand. Perfect. It's like sepsis, shock, bradycardia, tachycardia, right? And then type 3 MI, sudden cardiac death, right? By like VTAC or VFib, right? And then type 4 was PCI related. Type 5 was cabbage related. So that's more in the hospital, right? Any questions? No questions?